The ability to auto-populate data fields is one of the tremendous benefits of electronic medical records over paper records. And this post builds on the previous post discussing required data fields, because a part of having required data fields is potentially being able to auto-populate these fields using past data in a patient's chart and making it quicker to complete the form. But there are a few considerations that we need to look at in order to reduce error and reduce the chance that we just add garbage data into the medical record. The first thing we're going to look at is trying to create a system where users have the opportunity to confirm if the auto-populated data is either correct, incorrect, or if the user actually didn't review the quality of that auto-populated data. The second thing we're going to look at is the importance of storing the auto-populated data in a way where it's tagged different from data which is originally entered into the EHR. But first, let's very quickly look at some of the benefits of auto-populated data fields. The first is that you can essentially ask the user more questions on one form. For instance, let's say that you had a cardiac electrophysiology department that wanted to have a preoperative pacemaker implantation questionnaire. Now, if you had a paper form, the maximal tolerable length that this form could be that the clinician would actually complete it, let's say, is 20 questions, hypothetically. Now, if you had a digital form, in theory, you could auto-populate most of the fields from past information in the patient's chart. So this means that if you were to populate, let's say, for example, 80% of this form automatically, most of the time, let's say 95% of the time, you could populate 80% of the questions. This is hypothetically meaning that a 100-question-long form would only need 20 questions to be manually entered. And so as you see, essentially this means that a digital form could have 100 questions and have 80% of them pre-populated, and this would result in a total amount of work which is comparable to the physician who only has to fill out 24 questions on a form which is 20 points long. And so the benefit is that you're able to have more data flow upstream to the next user in line, downstream to the next user in line, and you can collect more discrete and structured data. An alternative way to use the benefit of auto-population is the one that comes to mind, which is that you can have faster clinical workflows. The fact that you could take a questionnaire with 20 questions, pre-populate the majority of it with existing patient data, will speed up the time to complete that form. And so, in the summary, the benefits to auto-population can allow you to collect more information or to complete the information quicker. And a clinic or hospital will need to really experiment with forms in practice to try to understand how much of these forms on average are able to carry over past information as they complete the form. So in theory, actually, you could use this for booking patients. You could imagine that before the patient is even booked, that you can look to see how much data a patient is lacking in the required clinical encounter form, and if the patient is missing quite a lot of information, you could book a longer appointment in order to get that information from the patient. All right, let's move into the second part now, which is actually trying to understand, is the auto-populated data true? Okay, there are two different ways which you can approach data auto-population. The first is that data by default is auto-populated into their respective fields when you open up a new form or questionnaire. The second option is to have a button beside the field where by clicking on that button, it would then auto-populate that particular field's data. The problem with the second option, though, is that in order to use that workflow, the user has to click the auto-populate button, see the data that comes into that field, review if it's accurate, and then if not, delete it and enter in their own data. And so my preferred method is that when you open the form, all the auto-populated data should carry forward from the past patient's charts into the current form, and you go from there. Now the key point, and this is, I would say, the whole crux of this post, and the most important part of it, is that the auto-populated data should be visually different on that form from original data or confirmed data. And we'll come back to that. And the second point is that a clinician should be able to sort the auto-populated data into one of three buckets. They either need to look at a piece of auto-populated data, and if it is incorrect, meaning that they've directly asked the patient the question and the patient provides a new answer, or if the clinician knows from another source that the auto-populated data is erroneous, that the clinician can then change the auto-populated field to the new correct data. The second option is that the clinician needs to be able to look at the auto-populated data, and if it is correct, meaning that they've explicitly asked the patient it or they've explicitly verified that piece of information themselves, essentially confirm that that field is correct. And the third category is that data needs to auto-populate in a form, but we need to identify the data which has neither been sorted as incorrect or correct, meaning that the clinician has not really looked into that data field with particular accuracy yet. We'll look at an example here on the screen in the video or a screenshot in the blog post, but as you can see, we have a question: has the patient smoked more than 5 cigarettes in their life? And we have the option no in a blue rectangular button. And that was the pre-populated field. And in this example, and this is just a hypothetical example, I don't even really like this UI, but you have a 3-point slider, and the button is set to gray in the middle. In the next example, what you could have is that if the clinician had actually clicked on the blue button, meaning that they asked the patient the question about smoking, the patient confirmed that they had never smoked, and now the clinician is essentially confirming a piece of auto-populated data. By doing so, the button is now a green rounded button in this case, so that the user essentially knows that that question is now holding information which is actually original or confirmed in that clinical encounter. And our 3-way slider now is showing the plus sign, meaning that the data has essentially been confirmed. You could imagine a hypothetical example where if the clinician had asked this question and then selected the opposite answer, yes, the patient had smoked cigarettes, that then we would have the new answer button appear, and the slider would slide to the negative side, showing that the question had essentially rejected the auto-populated data. Let's look at an example, for instance, of why this is useful. Let's say, for instance, that you have a clinician who completes the same form every follow-up visit. And they may choose in one individual visit to address and update only some of the questions. And they know that they'll see the patient again in a few weeks or in a few months, and at that time they'll update other information. By allowing the data to carry forward from encounter to encounter through the form and questionnaire, it makes it much easier to direct that appointment and for the clinician to have the encounter. But by using the system which we've just described, it makes it very clear when we save the data which questions were explicitly asked in the encounter, which ones were updated, which ones confirmed, and which ones rejected, meaning that the data has changed. Another way which this type of workflow is important would be if you had a questionnaire with, let's say, 50 questions, and you wanted 10 of them to be required fields. You could design that workflow so that the required fields had to either be, the required fields had to always be filled out, and they always had to be filled out with having asked the patient those questions, meaning that even if the required field was auto-populated, the physician then had to go in and either say that that field was, yes, correct the data, or no, the data is incorrect, and then update it to the new correct data. Now the question is what to do with the other 40 questions on this large 50-question questionnaire. Well, if the other 40 questions, let's say, were not required fields, you could allow them to auto-populate with past data, and then the physician could go through and try to fill in the gaps within those non-required fields that weren't auto-populated. And so if they had on average, let's say 5 to 10 minutes per visit to backfill missing data on this 40 questionnaire form, they could use those 5 to 10 minutes to try to fill in the gaps. And this is useful to the next group, which would be receiving this form, because quite often, for instance, in healthcare, we rely a lot on previous data. We often will look at past patient charts and try to use them to answer questions and understand about the patient's history. But auto-population removes a lot of the work of having to look through past documentation and places all that information at least into one single document. It carries it forward. And it's using the methodology described in this post, we're at least able to alert the user what information have we simply carried forward into this questionnaire to make it easier when you review all the information, versus what information have we carried forward and the clinician who saw that patient right now in time is also able to verify is still true or correct. We've now talked about the front end on how this type of information should be displayed and displayed in a manner which is different from the original data. And now let's talk about how the data is stored. I think it's very important that we separate in our databases data which has been asked in a clinical encounter as a discrete question, and we know that that patient, for instance, in that encounter has responded to that data point, versus information which was auto-populated in the encounter and neither verified as true or false, versus data which was auto-populated and then confirmed as true, versus data which was auto-populated and then actually replaced with a new field. So we have about 4 big buckets here of different ways which the auto-populated data perhaps should be tagged when it's saved in the database. And let me explain why this is very helpful. We know that one of the mantras when you start medical training is that you're often taught that the entire medical chart is full of lies, and that you should trust no one. Or at least that was what one of our mentors taught us going through medical school. And the reason for this, and this is very common, especially even on paper records, and we see the same, of course, in medical records, which are digital, but once something is entered in one clinical chart, essentially this information, even if it's erroneous, may continue to pass forward through the notes of people for years to come. And so having a skeptical mind about what information is actually true is very important. And this is why it's important to differentiate when we save the data, whether that data was actually asked in that clinical encounter versus if this data is historically carried forward. If you look on the screen here in the YouTube video or on the blog post, you see the question: has the patient smoked more than 5 cigarettes in their life? And we see that there are 14 squares arranged in time. The first 2 squares were the first 2 individual data recordings in the medical record, and the person had recorded yes on both occasions. Then we have 12 separate encounters, where on each encounter, the answer to this question being stored as no. The reason that this is important is that if we were to imagine that we were to use an algorithm or some sort of machine learning protocol on this medical record to try to answer the question, has the patient smoked more than 5 cigarettes in their life? If we used a protocol that used the frequency of occurrence to try to answer this question, we would say there's a very high chance that this patient has never smoked more than 5 cigarettes in their life, because the last 12 encounters that record this information show the answer is no. I've put the answers as yes in this question first, just to remove the concept of data temporality. You could imagine, for instance, that if the yes was at the end of this line, that dramatically changes the weighting. You can't really use frequency-based weighting, but just to make this simple, we aren't using the temporal relationship between the answer and the event. We'll move now to the next slide, where what we do is, it's just pausing. Here we go. On the second slide, what I've gone in and done is separated out which of these 14 fields were stored as verified data versus which fields were stored as pre-populated carry-forward data, which was not verified. And in this case, I've said that the 2 yes responses were each individual verified occurrences. The very first no response was a verified encounter, and then the subsequent 11 no's were all pre-populated carried forward data. And so again, if we were to think back to how would we analyze this with an algorithm, it's a very different occasion because we've carried forward 11 of the 12 no's, meaning that we have no veracity to whether that question has ever been asked of the patient again. So if we disregard all 11 of those 12 no's, we're now left with a ratio where we have 2 encounters saying that the patient has smoked and 1 encounter saying the patient hasn't smoked. This is a very different situation than the example above. I'm not going to, in this article, propose exactly how the algorithm should balance out what the correct answer is, but for certain, the certainty of what we can say about this patient's smoking history is much more ambiguous than in the previous example, where we thought we had 12 recordings of saying the patient has not smoked versus 2 recordings saying that they had. All right. Now, of course, what we didn't discuss is that sometimes a clinician may also deliberately delete a piece of auto-populated data, which is now incorrect, and replace it with a new piece of data. And so by at least storing the new piece of data in a slightly different way so that we know that that data is replacing and clarifying what is considered incorrect past data, we could figure out in some way with the data scientists on how to handle this information. Because again, using a frequency-based approach, it wouldn't work. Because in theory, the strength of that new single data point, which replaces the past data points, may outweigh all the past data points. Of course, you'd have to have in the system a check so that if you are using a new piece of data to replace past auto-populated data, that you have a verification that this wasn't changed in error. But you get the point, and the importance of at least separating out carried forward data, which is saved as part of a form, versus carried forward data, which is actually asked again in that clinical encounter and then saved as part of the form. And so where are we going with this? Well, I think the next 2 steps we'll be discussing in the next post the concept of levels of data quality. We already began to discuss at the end of this post this concept of trying to understand the actual truthfulness and validity of a piece of data in the clinical chart. I want to continue this discussion next. There's also the question of how do we deal in clinical notes with the issue of copy and pasting of data. I think that that's actually a very different question and problem than data auto-population for discrete questionnaires and forms. In many ways, the solution to fixing the issue with copying and pasting data is actually lies much more in changing entirely our structure of clinical documentation. And some of that has been alluded to in the concept of program encapsulation, and again, will be discussed in a separate post in the future.